Dr. Clark, members of the Academy, welcome, and best wishes for an excellent meeting. At this point, ladies and gentlemen, the opening ceremony is hereby concluded and the scientific portion of our conference will begin. It is now my pleasure to introduce the moderators for our opening session, which has been titled Global and Rural Surgery. I'd like you to welcome once again Professor Ramsey from Cairo, Egypt, and his co-moderator, Tracy Sambo from Edenton, North Carolina, who will guide us through this session.
I did not realize there was a microphone on this table, and I took my sheet up to that microphone, so my apologies. So just for housekeeping, we ask that you please jot down your questions, and then we'll save whatever remaining time we have at the end for the questions. And also, just a little housekeeping, unfortunately, Dr. Elahi is not here, so that talk will not be happening. Our very first speaker is Dr. Siva Vithiananthan, and he is an associate professor of surgery, clinical educator at Brown University Alpert Medical School, chief of minimally invasive and bariatric surgery at the Miriam Hospital in Providence, Rhode Island. His topic is teaching trauma and laparoscopic techniques and academic pursuits in a teaching hospital in Sri Lanka.
Thank you, Dr. Sambo and Dr. Ramsey. Thank you, presidents and ex-presidents. My talk today is not based on pathways, not based on a lot of data, and hopefully we get this experience and maybe come up with a plan, a better plan for the future. So let's see, I want to make sure I know how to advance this. Okay, I have no disclosures, except I do like warm weather. So Sri Lanka is a tiny island of India in Asia. It has a population of 21 million. The per capita income is about $11,000. And it's the size of West Virginia, but the population is 21 million. So you can see it's a very densely populated area. It is, in fact, a beautiful island. I grew up there. In Sri Lanka, but left during the Civil War. My only real last visit to Sri Lanka was during tsunami, when I was part of the group of surgeons, including Dr. Thambipillai, I think, went there to help out. And it was a very traumatic experience being there after so many years and seeing. And even though I do a lot of trauma in my previous job, I was not really ready for relief missions. I thought that was too much for me to handle. So then, a few years go by, and then 30 years later, the war had ended, and things were coming to normal. And before you know it, you actually started thinking like an American. So it was time for me to go back again, and I took the opportunity to go back, talking to different surgeons, including Vicky here, Vithiananthan, who's a past president, and Dr. Thambipillai here. And we said, we got to go back. And we all decided we'd go back at the same time to sort of support each other. We didn't know what people will expect us to do and whether they would be happy or sad to see us there. And this time, I also wanted to take my children so they knew where their roots were. So I've listened to many of these talks, and one thing I understood clearly was you have to have a local champion, and we had one. And he's someone who really guided us through this whole process, and he continues to do so. And I want to recognize Dr. Ambalawana, who's a urologist who sort of spent a lot of his time in Sri Lanka, but also had trained in England. So, when we went there, these are my children and my wife there in the middle. This is our ancestral house. The walls, ruins are still there, even though the background of the war is everywhere. You see it, you feel it, you're emotionally upset about it. But things are sort of moving along to normalcy. So the goals of my visit was to contribute as a diaspora, sort of test the waters. and introduced probably a different training model other than a British model that people are known to, and just focus on laparoscopy. It's an area that I'm interested in, and there was some, from what I understood, there was a lot of interest in building that. I also decided I would focus on resident training rather than going to do a bunch of cases and come back. And also the first visit, there was another group of medical doctors who were going, so I felt, collaborating with them and being part of going to a regional medical meeting would be a good idea. So in some ways I could, have some success if I address it in more than one way. So this is the hospital on the top end. There are a lot of still many wards, patients and their families are there at the same time. Even though right next to that is a very modern operating room complex donated by the Japanese government a few years before we had arrived, and it is as good as any of our hospital systems, but it does lack a lot of equipment. And this is the University of Jaffna, which is linked to the teaching hospital. I do have an affinity to that university. My dad used to be the president of the university. So I had a lot of connections there. When I went there, it sort of helped me. So when I went there, I was trying to figure out what is a model that I would use to teach them. Is it the U.S. model? Sort of take this model and duplicate it. So I was looking for a lot of sort of advice in the literature. There was none, really. My limited experience was going to Hungary and teaching residents there, and also being one of this ICS, U.S. surgical ambassadors going to China and teaching them. And what I learned from that is we always work with a local champion, and the language difficulties could be a major problem when you're training. I had the benefit of speaking the local language and looking like a local, so I felt like that was a positive thing. And then teaching styles, no one asks questions. When you go there, people all look very confused, but no one's willing to ask you a question, and that was something that I knew I had to overcome and try to get to them in a way that they feel comfortable. So this is probably a Western training model that I would use for laparoscopic training. Train people on, fundamentals of laparoscopic surgery. We would do an inanimate model, an animate model. We'll have workshops, have simulations, and then get them to the operating room in a very complex, interactive model. I felt like I couldn't do that when I went there. And so we had this little bit of a simplification of that model. I was going to build on FLS, the fundamental skills. I thought it was important and could probably get through that in short period of time. Have an inanimate workshop. We actually provided that. We took them with us and did a workshop. And I felt that I could do and also use that to get to know the people. And then do some simple cases. So the FLS, for those who are not familiar with FLS, it is a way that we train our resident. It is a requirement. Residents have to pass it to to be certified and accredited to get boarded. And it is to standardize training. It's based on teaching 5 tasks to master. Again, this is a fundamental course, not a master course. It starts out with the beads, putting the beads in pegs, cutting shapes like a circle, and using endoloop ties, doing extracorporeal suturing, and then intracorporeal suturing. And this is inanimate training model, trainer box that many of you have seen before and may have used it in the past. So anyway, these are the individual boxes. So that's what we use. And we use for the first couple of days, getting to know the residents, knowing their strengths. But our objective was to just train they call the registrar, the chief resident, we're going to just work with them. And so we did some lap choles, some inguinal hernias and ventral hernias. They did not have mesh, so I had to take the mesh with me, and you could buy the mesh. The patients had to buy the mesh. And then I learned how to do a lap varicocelectomy was done by one of the chief residents. He showed me how to do it. So that was pretty cool. And then we had a whole bunch of people in the back. These are all visiting surgeons from the region. And I felt like I was in the amphitheater, people like talking, and they were sometimes crowding around you. And it was 100 degrees, and the AC did not work. And that was one of the hardest things, doing an operation with all these people around you. But then we ran out of space, and we would put these people outside and have like live telecasts. And then we learned from this experience, and I'll tell you what we did the next year. And then after that, we also did a CME activity with the medical guys, have a joint session at their regional meeting, and also met with the medical school and the dean. Here's Tavam here, talking about how to develop long-term goals for the medical school, how to bring diaspora in. So they knew that we are here for long-term commitment. So what I learned in 2016, there was a true need for new technology and new teaching methods. There's significant interest, and they were embracing outside help. They were not close to it. There's collegiality, and we also, they wanted to build excellence and an academic approach. Even though they were coming out of a major war situation, they did not have any trauma training. And there's significant brain drain, and it was time to expand the surgical expertise there. So the next year, I got a new team to go with me. There was Dr. McCarthy, June Shem, Tom, the same old players here, and a neurosurgical resident. And Dr. McCarthy, she was also the first vice president of the ACS, but she was the chairman of my ex-fellow. You know, you always tell the fellow, well, I let you graduate, you got to come with me to a program. And so she got her to come. So it was nice because there's not many women surgeons in Sri Lanka, so we thought this would be a good message. So we went to Sri Lanka again, did similar things, basic laparoscopy that I did last year, we built on it. And then we do the team trauma course and advanced laparoscopy, okay? The team trauma course was run by Dr. McCarthy, who was a trauma surgeon and a program director. She's built a tremendous program in Ohio. We had dummies and real people, and we went through a training for the house officers. This trauma training is for senior students as part of a pre-ATLS program that the Committee on Trauma runs, but this is well received. We had a full day's program. 30 house officers joined in. Local faculty were observing what we were doing, and then the site was given an approval by American College of Surgeons to do future courses. They certified the center. It was a big deal for them because the closest place they could do was in Singapore, and most people couldn't go there. So that was a major victory. We also showed them how to do fast exams. They had ultrasound capability but did not have the expertise. So we trained all these house officers how to do fast exams. And then we used Dr. McCarthy as model for the young students on leadership, about women leadership in medicine. But I don't want you to think that it's a closed society. You know, the first women prime minister in the world is from Sri Lanka, so they had women leaders all along. And the previous president of the university is a woman as well. So there's a lot of women in leadership, but not in surgery. So this is a important thing that we sort of try to bring home. We did some dry labs like we did before, but with this time, we actually took these, got enough funding to get these portable machines that can work out of cell phones and iPads. So it was easy for the residents to take it home and learn. And everybody had an iPhone there. I mean, So, and this time the operating room, not only we did do basic surgery, but we also did some a little bit more complex surgery, and also used this opportunity to get the faculty trained. Okay, so they wanted to be part of this training, and so we got a lot of the faculty to help out, and we worked on dissection, suturing, and energy use, and that was the focus. So again, same group of people here, but what we did was we had a couple of surgeons outside explaining from outside while some were operating inside, so we were able to decompress the OR a little bit, but have the same experience for the visiting surgeons. So again, we paired that with a meeting. We actually, this time, were part of the College of Surgeons meeting. We contributed to that. The surgeons contributed to the discussion on trauma. We talked about portfolio-based training for residents, medical school clerkship, how to teach differently and how to evaluate differently. And then we really hit hard on research paper presentation, how to do research. There were about 20 papers. We critiqued it, gave helpful suggestions for writing up, and had the president of the Sri Lankan Surgical Society was there. We got him to agree to have at least 2 papers get like a direct review for the journal, which was a big win for the residents because they automatically got a review for publication. It was not just work. I mean, we had a lot of food and fun. And so what happened? So when we left, is that the end? So since then, I've been keeping tab of it. One of the things that people who have gone to trauma lectures have about the Scudder Memorial Lecture, which actually his brother was the first visiting American surgeon in Sri Lanka in the 1800s. And so there was an article about Scudder that was written by Dr. Amalawana, the local champion, that got published in my alma mater's Columbia Medicine paper because he was a Columbia graduate himself. So he wrote about his missionary work in Sri Lanka and South Asia. So that got attention in the US and in my medical school. We have then, since then, they have done a team trauma course run by the local faculty within 6 months of being there. Now the medical students had attended that because the medical students who were in strike for 2 years for some, from political reason, are back to school. Now they can attend classes. Okay, and so now this is being certified by ATLS. We have also had the Committee on Trauma had invited one of the orthopedic surgeons who had started a database, inviting him to work on developing an international trauma registry, and they got him in here, and Dr. McCarthy helped him to come in and present his database. And then what's other thing that's important is to continue to keep connected. We have a WhatsApp group that has all the surgeons bouncing ideas and discussing difficult cases and sharing best practices, journal articles. So there's this international community sort of engaging with the local surgeons. And so I think since then there's also been another meeting, a British group of people have gone there and worked on nurses and colorectal surgery. Even they are talking about ERAS now. So what are the 3 outcomes of a teaching mission? I think there's a intellectual curiosity. There's a lot of focus and attention on papers and getting young people involved. We've also backed it up by giving a significant cash award every year for the residents to the best papers, which got a lot of attention. We have given them access to the U.S. Surgical arena for attendings to present and get their papers published. We've been collaborating with outside surgeons, and team trauma course has been introduced, and that's a big deal. And the laparoscopy workshop is continuing on. It is sort of continuing to work, even if we didn't go this year, it's going on. And then the establishing the WhatsApp group was also a big victory. So in conclusion, there's lack of data in literature and best practices on teaching surgery overseas. We have a lot of our residents go there, but there's not much about teaching. I thought the training program overseas had a positive impact. In my experience, in a short period of time, we have made an impact, and there's always nice to have a local champion who can guide the process along. Long-term success really needs further study in terms of what is the high yield method, so we can follow that. This is an area that ICS should take leads on, and this is one of my interests to actually have a book on how to go and do these missions.
We're at
for
18
people who
minutes.
and final comment, the ICS Surgical Ambassador program should be probably investigated further. Thank you again. I'm sorry I ran over time.
Thank you, Dr. Vithiananthan,
Yep.
for quite an interesting talk, speaking about what is happening with this in your country. And now can I call on my dear co-chairman, Dr. Tracy